Greetings to everyone who's joining us. I believe our session is now live. My name is Peter Berman. I'm a professor at the University of British Columbia and director of our School of Population and Public Health. And it's my pleasure to welcome you to this session today on day 4 of the conference on creating and nurturing platforms to facilitate the use of research evidence in policy decisions experienced from Ethiopia. Before I turn the floor over to my distinguished colleagues in Ethiopia, I'm speaking to you from Vancouver, Canada, actually, quite late at night. I want to tell you a little bit about the work that we've been undertaking together. So the work that we're going to share with you this evening is part of the work of a project in Ethiopia called the Fenot project. Fenot refers to a bright future for Ethiopia. And this is a project supported by the Bill and Melinda Gates Foundation and is a continuation of work that we've been doing in Ethiopia now getting close to about 8 or 9 years. The focus of the Fenot project is on trying to make evidence that is available in Ethiopia more useful for policy and program decisions to improve policy and improve health program performance. Ethiopia is not unusual amongst many countries in that it has actually quite a rich reservoir of evidence, much of this being collected by the Ministry of Health and government directly through national surveys and other studies, but also much of it being collected through the projects of different divisions and departments in the Ministry of Health and the work of a wide range of international partners. Also, I think not atypical from many countries, there's a sense that the use of this evidence for policy and program performance improvement is not as good as it could be. And so the question really is, how can one create a more useful and functional and effective evidence to policy channel? We've been working on that question at the national level in a range of different areas, but also working on that question with regional health bureaus at a subnational level. My colleague, Professor Mukhuzi, is controlling the slide, so I'm going to ask him to advance to the next slide. As you can see, that's me by way of introduction. And to the next slide, please, Mukhuzi. And why don't you fill in that slide with the contents? Great. Okay. So our session today is organized around 5 specific presentations by different colleagues. The first of these presentations will explore the overall evidence to policy landscape in Ethiopia, and that will be done by Professor Tsinuel Girma, our project director in Ethiopia. The second, mechanisms and platforms used by Fenot to enhance evidence to policy functions, and this will be presented by Professor Mukhuzi Waldi. The third presentation on evidence generation for quality of healthcare, presented by Dr. Bereket Yacob. The fourth on evidence to mobilize domestic resources for health by Dr. Girmaya Dinsa. And the fifth on supporting data generation and use at subnational level by Dr. Tista Tilahun. We'll go for about an hour, and then we're going to have about another hour to open up for question and answer and any discussion between participants and the panelists. So on that note, I will conclude my introduction and ask Professor Mukhuzi to advance to the next slide and turn over the floor to Professor Tsinuel Girma. Thank you.
Thank you, Peter. I also welcome our participants for joining this session. So as Peter said, I will be taking you through briefly on to describe the landscape of evidence to use in Ethiopia. And I will follow this outline. I will be briefly giving overviews on the Ethiopian health system, and also overview on the evidence-informed policymaking process, and give you some highlights on the context, the policy context, and the challenge. And finally, I will touch upon certain recommendations. Just to give you the highlights of the Ethiopian profile, as Ethiopia is located in the Horn of Africa. It's neighboring with Eritrea, Sudan, South Sudan, Kenya, Somalia, and Djibouti. And it's popularly known to be the origin of the humankind and the popular coffee, and it's also a nation of great learners. Roughly, the population is around 100 million, which is the data from 2017. We don't have the latest census, with close to 1 million square kilometers of land. The life expectancy average around 66 years. And the certain indicators like neonatal mortality, infant mortality, under 5 mortality, and maternal mortality put Ethiopia at the bottom line when compared to other African countries, as they are relatively high. We have, Ethiopia has several research and training institutions. Just to give you a sense of what we have more than 40 public universities. The health system in Ethiopia is structured into 3-tier system. The major bulk is the primary healthcare level, both for urban and rural. And secondary, tertiary are mainly hospital level and tertiary hospital level care. And as you see in the rural context, we have the health centers, and they have also the village level, what we call health post. These are really the key elements in implementing and also availing primary health care services to the community. And these are staffed, uniquely staffed by at least 1 or 2 health extension workers, which are trained for 1 year. They are formally employed by the government. And we have also community network, community mechanisms that work closely with these health posts, and then they are organized under what we call Health Development Army. These are mainly led by model families and also prominent women in the community. Ethiopian health sectors have been guided by strategic documents for the last 4 decades. And the last one was the health sector transformation plan. As you see, it has expired on this year, and we are preparing the second one. It has several strategic objectives, and one of the key, maybe which is relevant for our discussion today, is an improvement or research and evidence for decision making. And the document has identified 4 key components. And the first one is the health, of course, the policy and the planning component, and having the proper health information system, and supporting and nurturing health research, and last but not least, also the knowledge management system. Just to give a brief account on the evidence-informed policy-making process, as you all know, it's not a linear and simple process. It's very complex, with multiple agents involved from multi-sectors, be it community, health, governance, education, research. And there are connections and networks among these stakeholders, and they can be at different locations and have different mandates. But this is really a complex environment. And we have done, our team has done a review of the evidence-informed policymaking in Ethiopia like 4 or 5 years back. And this was what we have formed from this review. And as you see, we have 2 components, the structure and capacities, and these are all interlinked. And the 2 pillars among the structures are policymakers and the researchers. And for these 2 to function effectively, there should be a mutual understanding, trust, and there should be also a very strong and effective bridge to bring these 2 actors together, and then effect all these displayed functions and have a properly functioning evidence-informed policymaking process in the country. The ecosystem has, as I've already said, it is a very crowded space with multiple agents and with multiple sectors. And just to put them in the different phases of the evidence policy process, under the generation, we have the government ministries, private research institutions, regional health bureaus under the system. This could be also playing a role of synthesis of evidence and finally to be used by the implementer agencies, including the parliament and the ministry. Of course, all should be brought together under a legal framework and the institutional arrangement. And then so they need to have a culture of using evidence in the policymaking process. There are certain challenges, of course, as anywhere in the world. The Ethiopian health system is not unique. And these are some of the challenges that we have identified through our review and some of the literature that we published from other places. The first one is the absence of an effective coordinating mechanism. Ethiopia is lacking this system, which is really, really important in terms of putting the proper structure and overseeing these functions. Another issue that was identified through our review was difficulty in accessing already existing data. As Peter mentioned earlier, Ethiopia is rich in data that is being generated from different sources, including the ministry and the regions. But these are really often difficult to get for use. The other is the lack of also evidence whenever there is a policy issue that is tabled for discussion. Usually there may not be evidence. Even the available evidence are not usually consistently properly analyzed. Even that's also the analyzed one are not properly optimally used. So these are some of the challenges that have been identified through our review. And the root causes, just to take you back to the frameworks that we have already displayed, are the structural issues, capacity issues, and linkage. Just to give to take some examples from structure, as we have already said, there is an inconsistent and engagement and coordination of stakeholders. From capacity, there is a rapid turnover of staff from the ministry and the regions, from research institutions. And of course, there is a gap in the capacity to use evidence and synthesize evidence. And there are certain institutions like Ethiopian Public Health Institutes, which are mandated to lead the process of this function, but usually they are busy with other competing priorities. So they don't really give full support to this evidence-informed policy-making process. And as we have already said, there is a major gap between the policymakers and researchers. Finally, the recommendations. Of course, it's not an exhaustive list of recommendations, but some highlight, to give you some highlight. We need to have a governing body or mechanisms that should effectively coordinate these functions. First, developing clear guidelines, procedures for priority setting, evidence generation, synthesis, use, and capacity building. The other is this effective coordinating mechanism could also be working on identifying resources for evidence synthesis and evidence generation, pooling the resources, allocating the resources to implementing institutions. And finally, most importantly, also giving an oversight and general guidance for this function. So I think this is brief what we have to give you some sense of the Ethiopian context. And my colleagues will follow and will build on this some of the concepts that we have already said. Thank you, Peter.
Okay, thank you, Sinduel. Thank you very much for that great introductory presentation. I apologize. There are a couple of things I should have mentioned when I did my introduction. The first is that there will be time for questions and discussion after the formal presentations, but please enter your questions on the conference platform webpage for this session. You will see on the right-hand side an area with live Q&A. And if you click on that, you will be able to type in a question and I will be able to see the questions and ask them afterwards. Please do not try to put the questions in the chat for Zoom. Those won't get through. So use the conference website platform and the page for this session. And also I did neglect to mention that our work in Ethiopia is a partnership involving Harvard T.H. Chan School of Public Health, the University of British Columbia, and the Association for Better Health in Addis Ababa, India, which hosts our team, which is presenting to you today. So now let me give the floor over to Professor Merkusi Wolde, who will speak on some of the mechanisms that we have been working with our colleagues in Ethiopia to try to improve the evidence to policy functions. Merkusi, over to you. You are muted, Merkusi. There you go.
Thank you, Peter, and thank you all who have joined us on this presentation. So I will be talking about what we did in Ethiopian health system to enhance evidence to policy functions. I will be building on what my colleague has already presented about the challenges and the problems related to evidence to policy functions. So I'll talk about the direct technical support we provide, the evidence to policy platforms we have assisted to create and maintain, and also see about regular evidence presentation sessions and the national research conference that we support, and finally the capacity building works that we do. A bit of background about Fenot. Of course, Peter has already said a bit of it, but some have joined the presentation late. So this project, Fenot, is a project which intends to support the primary healthcare system in Ethiopia, and it builds on earlier projects funded by the Bill and Melinda Gates Foundation. So it's like a continuation of those projects which work to introduce innovative solutions to develop a strong primary care system in Ethiopia. And the overall aim of the current project, Fenot project, is strengthen Ethiopia's primary healthcare system through generating and applying relevant, high-quality evidence for decision-making and service delivery. So to give you a highlight on what we did, the mechanisms we used to enhance evidence to policy functions in the Ethiopian context, there are two technical areas. So we work in the evidence to policy area and the health financing area. And the levels, we work at national level with MOH, with different departments in the MOH, including Maternal and Child Health Directorate, Partnership and Coordination Directorate, Quality Health Services Directorate, and Clinical Services Directorate. So several directorates work with us, and at subnational level, we work with the Oromia Regional Health Bureau and the Dredwa Regional Health Bureau. So we provide this support, which I mentioned earlier, to both levels, at national and subnational levels, and to the ultimate purpose is to enhance use of evidence to make a decision in relation to quality of health service and health financing. So to give you a bit of a detail about each of the mechanisms we have used to enhance evidence to policy functions in Ethiopia, Fenot has got high quality, high caliber researchers in its team in the area of health policy and systems. So we use the skill of our team to collaboratively work with policymakers and health managers in subnational and national levels. And through that, we help them identify and prioritize policy issues, work on existing national database to answer those policy issues. So we support the staff at the ministry and regional health bureaus to identify policy relevant research questions, prioritize those questions, and then do analysis of existing data sets. As earlier mentioned, there are a lot of data sets, including DHS, SPA, SARA, HMIS, and the DHIS2 currently. So we use these data sets to answer the policy relevant questions posed by the staff at the health system. And in the course of crafting the questions, prioritizing the questions, and doing the analysis, we work with the staff of the MOH and the Regional Health Bureau, and this has helped us to co-create the questions and the answers and build capacity at the same time. And we don't only, prepare reports and send it to the staff at the ministry or the regional health bureaus. We do presentations, and we also facilitate policy dialogues in the presence of several stakeholders in the health systems to make sure that our findings are taken up for making decisions to improve quality and health financing in the health system. Another platform we have been supporting for the last 5 years is the RMNCAH Research Advisory Council. This is a national platform to enhance evidence to policy and particularly focuses on in the area of maternal and child health. It was established in 2015, and members come from different researchers and health program managers from universities, FMOH itself, and partner organizations. So they come together, because actors are disconnected, because those who generate evidence and those who are supposed to use evidence are not connected properly. This platform has enabled to bring all actors together and work together to identify questions, do analysis, and enhance use of evidence in policymaking. There are 7 thematic groups like for family planning, adolescent and youth health, neonatal health, early childhood, and others. And each group receives a question from a relevant section of the Maternal and Child Health Directorate every year, a question or 2 usually, and they work on that question, of course, with the involvement of the staff of the directorate, and prepare policy briefs. Particularly, usually they do systematic reviews to answer, to bring local, regional, and international evidence together and answer the policy relevant question posed by the staff at the Department of Maternal and Child Health. And finally, they don't only prepare a policy brief and submit it to the team at the ministry, they also facilitate and engage, do presentations in policy dialogue sessions in the presence of stakeholders to make sure that findings are used. Another platform is at subnational level. We have learned from our experience at the MSH Directorate at national level and the Ministry of Health, and we have duplicated, somehow similar structure at subnational level, particularly in the Oromia Regional Health Bureau. And it was established very recently in 2020 and composed of researchers and health program managers from universities or Oromia Regional Health Bureau, and of course, partners. And there are different thematic groups. Peculiar to this advisory panel is this the group works on the entire health system, not focused on a particular program as we do it in the MSH Directorate of the Ministry of Health. So we have thematic group for financing, for governance, human resource, and things like that. So each group receives a question from the Regional Health Bureau and works on the question to make sure that evidence is synthesized and forwarded to the team at the Regional Health Bureau. Another platform we have created to enhance appetite for use of evidence at the national and subnational levels is the regular evidence presentations we facilitate. We have the Agalgil, Gala, and Money Talks sessions. The Agalgil session and Gala session, these are sessions at the Federal and Regional Health Bureau. Agalgil and Gala sessions, these are equivalent to lunchbox or a food container in local language. And this is a session similar to lunch and learn session, and it happens every month, sometimes twice monthly. And Money Talks happens at the, it's specific to financing and happens at the Partnership and Coordination Directorate. So what do we do in these sessions? We invite researchers and health program managers from universities, Ministry of Health, Regional Health Bureau, and partners, and they share their new research findings with the staff of the ministry or the Regional Health Bureau. The topics are usually those preferred by the MOH or Regional Health Bureau people. The staff then is provided with local, regional, or sometimes global evidence which is relevant to what they do. And we have witnessed that this has really enhanced the appetite for use of evidence. And our role here is to do organization, provide technical support, and of course, financially support the lunchboxes during the sessions. Another substantive support we provide to enhance evidence to policy functions at national level is supporting the biannual National RMNCAH Research Conference. This conference aims to identify high quality research reports related to RMNCAH in Ethiopia and beyond, and organize oral and poster presentation sessions to make sure that these are presented to participants in the workshop. We also organize side meetings, skill building sessions for capacity enhancement. And this is also an opportunity for networking for researchers, partners, policymakers, and professional associations, which are key players in the evidence to policy function in the health system. This conference happens every 2 years. The first one happened in 2017 and the second in 2019. So the next one will happen this year. And finally, a very important piece of work we do to ensure evidence to policy function is enhanced in the Ethiopian health system is building capacity the staff at MOH and regional health bureaus. The first approach to enhance capacity is hands-on capacity building to the staff of MOH and regional health bureau. We do it in 2 ways. One, one-to-one support by experts from Fenot to staff of MOH or regional health bureau. How do we do that? As mentioned earlier, they identify questions and forward questions to make sure that they use best available evidence in making decisions with their work. And when they pose questions, we help them craft that question, do search of relevant evidence if it is already available out there. Otherwise, we do analysis together on the different existing data sets, which we mentioned earlier. And of course, we also engage them in the evidence to policy platform. They actually serve, they facilitate, lead the thematic groups, the relevant thematic groups to their work in the Research Advisory Council at national level and in the Scientific Advisory Panel at the regional level. So engagement in those platforms would enhance their skill of crafting questions, doing prioritization and doing search, and of course, synthesizing evidence to enhance use of those evidence. This also applies, of course, to the university staff join the platforms. Another approach to enhance capacity is providing tailor-made workshops which target the MOH, regional health bureau, and other actors in the health system, including professional associations and partners working in the health system. In this session, we do interactive sessions with case studies and group discussions in several topics, including financing, health systems as complex and adaptive system, policy making process, analysis approach, evidence-informed decision making, and question framing, prioritization, and communication of research findings are included. So in these sessions, we make sure that what the participants receive is relevant to what they do and is helpful for improving their capacity in identifying, synthesizing, and using evidence, and of course, bargaining for use of evidence in making policy decision and in negotiating with other actors in the health system. Thank you, Peter.
Okay, thank you very much, Professor Mercoussi. And I want to just mention that we currently have almost 100 participants in this session. And I've been receiving a bunch of questions. So I'd ask you, if you post questions, especially ones that are more general, please be patient. We will come to them in the discussion section. But one question that was posed, Mercusi, that I think directly relates to your presentation is how can people in Ethiopia participate in the conference that you mentioned? And I think you're on mute over there.
Do you want me to respond now, Peter?
Just briefly to that one question. It's very, very focused.
Yeah. So this conference, there is no like a fee for participation. We actually we make sure that we mobilize resources to support researchers from different parts of the country join the conference. We support their accommodation and subsistence to make sure that people who do not have the means to participate join the conference. Otherwise, those scenarios, without fees, they join the conference. That's how we do it. It's open.
Thank you very much. I'll come to the other questions in the discussion section. So our next speaker is Dr. Barakat Yacob, who's going to speak specifically about evidence generation for improving healthcare quality. Barakat, please go ahead.
Thank you, Peter. And I would like to welcome and thank everyone who has appeared for this session. So in this session, I will try to exhibit some of the works of the different platforms that have been formed under this project, the Fenot project. So what I will do is I will just try to tell you or show you some of the achievements of this platform. So I will talk only about one of the platforms. We have a number of platforms, but due to time constraint, I will speak only about one of the platforms that we formed. And I will also try to show you or exhibit some of the works. So as I said, one of the platforms that is formed is the Ethiopia Quality Commission. Initially, it started as an analytic core team, which is expected to do a number of analysis of priority topics in Ethiopia. But later we changed that team into Ethiopia Quality Commission, which is formed under the Lancet Global Health Commission for High Quality Health Systems in the SDG era. So initially it was an analytic core team. So later what we did was because they had the same purpose with the Ethiopia Quality Commission's intention. So we merged the team with Ethiopia Quality Commission and we formed that platform to assist the Ministry of Health in carrying out different analysis of priority topics. So this is a voluntary team, which was launched in August 2017, and the purpose was to measure and describe quality of care in Ethiopia. So under the call by the MCH Directorate, the Maternal and Child Health Directorate, we had about 20 experts from different sectors, including the Ministry of Health, different universities in Ethiopia, different research institutes like Ethiopian Public Health Institute, and different implementers. So we had about 20 experts from these all institutes. So this commission identified initially the commission identified about 10 priority topics, but later the team or the commission engaged on about 7 topics, which were prioritized by the Ministry of Health, the MCH Directorate. So following, I will show you some of the findings of this the Ethiopia Quality Commission. The first, the topics, these 7 topics that I mentioned earlier, the first one was about effective coverage of family planning and antenatal care in Ethiopia, which was accomplished and it was published. And the other one was equity of distribution of quality MCH services. This was aiming to show who was benefiting from the quality of
MCH services in Ethiopia. And the other one was know.do gap on sick childcare in Ethiopia. We used, for all of these analysis, what we did was we used existing data. We didn't go to the field to collect data. But what we did was, as it was mentioned earlier, we have a lot of data which has not been widely used. So we encouraged the team members to use existing data and come up with some very informative findings. So the first one was capacities and facilities readiness for TB, HIV, malaria services in Ethiopia. And again, the other team worked on availability and readiness of primary health care units to provide kangaroo mother care services in Ethiopia. And the sixth one was quality and differentials of family planning services in Ethiopia. And the last one was dietary quality and the limiting factors in Ethiopia. So the 7 teams, because the 20 experts were grouped in these 7 teams, and they worked and they finally either published and also presented their findings to the MCH Directorate or different conferences and fora. So I will show you a few findings from the analytic works. The first one, as I mentioned, this was published and you can also access it from websites. So it is about low effective coverage of family planning and antenatal care services in Ethiopia. So the motivation was, this is not unique to Ethiopia, but many developing countries, these days, policymakers and experts are very much interested in conducting measures for coverage of different services. But, there is a lot of scarcity regarding the quality of these services. So, and the governments usually, they are interested in talking about the coverages, but because of lack of evidence about quality of care, they don't talk about quality. So with this motivation, what we did was we tried to look at the existing data, which is the existing data, 2 different data sets. The first one was service provision assessment, which was conducted in 2014, and the other one was the 2016 DHS survey. So what we found from these sets of data was very interesting. For instance, antenatal coverage in Ethiopia in 2016, the national coverage was about 62.4%. But when we adjusted that for quality, it became quality adjusted coverage was about 20.7. And you can see these are regions, about 9 regions and the 2 city administrations, overall 11 regions. So you can see there is a lot of variation in the performance regarding the coverage, the crude coverage versus the quality adjusted coverage. So you can see a lot of gaps or on quality adjusted coverage versus crude coverage. Again, this is about family planning coverage, effective versus crude coverage. You can, again here, you can see here that the mid family planning coverage was about 60.6%, but the quality adjusted coverage was about 20. So to mention how we created this quality measurement, what we did was we created an index for quality from observed quality. That is to mean there were people who were standing by the service provision area and who used checklists to document how the service was provided and what contents were covered in the care provision. So using that data, we created an index for each of the analyses that we carried out. So you can, again here, you can see wide variation between crude coverage and effective coverage of family planning services in Ethiopia. The other analytic work that the Quality Commission conducted was the know.do gap analysis in sick child care in Ethiopia. This also showed a big discrepancy between the VNets, which measured the knowledge of care providers in providing sick child care, which is actually to mean IMCI, Integrated Management of Childhood Illnesses. So here, the team considered two things, the assessment aspect as well as the treatment and counseling aspect. So in assessment aspect, you can see medical doctors knew about 50% of the expected procedures and during the assessment, while in the observation, only 36% of the medical doctors adhere to these guidelines. So that showed about 14% gap between knowledge and the two aspects of care, which was statistically significant. Again, you can see here health officers, health officers are also clinical officers, somewhat equivalent to clinical officers. The knowledge aspect was lower compared, I mean, it's generally for all types of the disciplines, you can see knowledge was not going above 50%, but the observed or the performance or adhering to the guidelines was about 36 or 37%. So the same is true for treatment and counseling aspect. Medical doctors knew more about the treatment and counseling, but the practice was much lower compared to the other disciplines. Overall, you can see medical doctors, about 18% difference was observed. In other disciplines, it was about 9% or 3%. So there was a huge knowledge and do gap in sick child care. The other one was capacity of health facilities for diagnosis and treatment of HIV/AIDS in Ethiopia. This assessment or analysis showed wide discrepancy between health centers and public hospitals. In Ethiopia, health centers are mostly, or I can say, all of the health centers are publicly owned, while the private facilities have clinics and hospitals. So the assessment showed that they varied widely regarding the structural indicators, which were considered as like the referral capacity, presence of separate rooms, and supervision, practice, and availability of trained personnel. So the readiness of the facilities was very variable, and the process indicators also showed the same gaps. Like it ranged from 33% in HIV counseling to 68%, and so on. So to show you what I said in map, so this is the regions of Ethiopia. So you can see here, there is the overall capacity of health facilities to provide HIV/AIDS capacity and HIV/AIDS treatment and diagnosis. So you can see here the red shows the capacity is higher, but the greener one shows the capacity was lower across the country. So to wind up what I have been saying, there are some insights and lessons that we learned from carrying out these analytic works. The first one was we observed that there is improved appetite at the Ministry of Health to measure and describe quality of care and make evidence-informed decisions and improvement plans. So because we worked with the ministry staff, they knew everything that was done, the analytic processes that we followed, and the findings of this analysis. So they knew everything, and it was not difficult for us to help or to advocate for use of this evidence. So there were a lot of efforts made by the ministry to use the evidence based on for instance, based on the equity, the effective coverage analysis. The ministry initiated a number of initiatives to improve quality of care and to use the data in making decisions. The other one is, as I said, whenever the analysis is done jointly,
there is increased chance of that output to be used by the ministry. And the Ethiopia Quality Commission has brought together a number of actors in the country, evidence generators and the users, and contribute to quality improvement plans in the country. And the final thing that I would like to say is some of the findings of the Quality Commission pose more questions, because the effort made by these Quality Commission members was to describe and measure quality, not to answer some of the how and why questions. So these were some of the questions that came out during the analytic work and during the dialogue that we created, or the team did with the ministry staff as well as different research institutes. So these are just some of the outcomes or outputs of our work, our support in Ethiopia, but there are a number of platforms and other outcomes or other exhibits that we would like to share with everyone. I think I have to stop now because time doesn't allow me to go further. Thank you.
Okay, thank you, Barakat, for your presentation. And if we could advance to the next slide, please. And I want to assure everyone your questions are coming in, and I'm seeing them on the platform webpage. So our next speaker is Dr. Girmay Dinsa, who's going to share with you some of the work that they're doing on making evidence available to strengthen domestic resource mobilization. Girmay, over to you. We can see Sinuel there, but not Girmay. There he is. Unmute, you're on mute, Girmay.
Okay, I did. Thank you so much, Peter. So I'll be talking about another case study for evidence to policy. Specifically, this is on health financing or domestic resource mobilization. So in my talk, I'll cover some of these bullet points. I'll give you a background specifically to this case because my colleagues have spoken about the context of Ethiopia. And I'll also talk briefly about the initiatives for evidence generation, how they are kind of initiated, and the process itself for generating evidence, and also what kind of dissemination and advocacy activities need to happen for an effective evidence to policy. And finally, I will conclude my talk by emphasizing some factors that affect evidence use for policy. So just to give you a quick background, if you look at the Ethiopian health financing data, you would see that in the last 10 years or so, Ethiopia received between 35 to 50% of its health expenditures from external sources every year. And these resources are usually used for basically essential health services, such as providing, HIV/AIDS testing and counseling, providing maternal and child health services, malaria treatment, those services that are kind of deemed essential for the public health in general. And recently, we observed that some of the supports or external supports are declining. And this fact is kind of concerning for the Ministry of Health. And therefore, they would like to look at ways to replace donor funding in general. And because of that, the then Minister of Health, Dr. Amir, established a think tank group to look at or explore potential or possible ways of looking at more domestic resources. And so I was a member of that think tank group from the Fenot project. So another aspect of evidence to policy is identification of evidence need. So for this case, the think tank group recommended to explore potential resource mobilization from domestic sources, and also to look at some of the innovative ways of resource mobilization. And so the Financing and Resource Mobilization Directorate at Ministry of Health formed a technical team to explore whether it's possible to generate some additional resources through tax and non-tax mechanisms to kind of offset the resource decline from external supports. And to give you a quick highlight on the evidence generation process itself. And so I was, as a Fenot senior health economist, I was a member of the team that looked at this potential. And so the team included health specialists, public health specialists, statisticians, and these are civil servants at the Ministry of Health. And so they were included in this team to explore potential ways of mobilizing more domestic resources. And we looked at tax on these products called sin products, such as smoking, tobacco, alcohol, and chat is kind of a stimulus plant that's commonly used in Horn Africa and some of the Arabian countries. And so it's a bit controversial. Some people say it should be banned, and I think it's banned in the UK, for example, in the last 10 years or so. But it's an important source of revenue, and so we wanted to explore these products because A, they have a good public health effect because consumption of these products are assumed to have health benefits. And two, by doing so also, it's possible to raise more money or revenue for health. So there was some data collection from major producers of these products, as well as there was a literature review by the team to look at, what would be the effect of tax, what's the potential for additional tax revenue from these products, what's the effect on consumption, and so on. So as I said, production, consumption, and socioeconomic inequalities were looked at, and as well as potential revenues that could be generated for different rates of increase for taxation. And actually what we found was that we concluded that it was possible to generate something like $1 billion USD over a 5 years period if the government increased just between 5 to 10% of taxes on these products. And to also give you a context what that means, it means it covers about 80% of what external donors provide per year for Ethiopia for the essential services I discussed earlier. And discussions were made with several stakeholders, mainly with the ministry's different departments, to make sure that they understand what the findings were. And in terms of the dissemination, so as I said, there were several discussions that took place within the directorate in the ministry itself, and also with key stakeholders, including the Minister of Finance, that's responsible for collecting tax and generating revenues for government, and also for the Ministry of Health's technical working groups, including the Ministry of Health Management and the minister himself. So these discussions were kind of two ways. Always they were asked to give their feedback, which were included in the final paper. And we also prepared a policy brief, which is less technical document to help everyone, especially program managers and ministers in every relevant ministry, so that they would understand what the finding means and their policy implications. And there were also formal as well as informal discussions and advocacy with policymakers, program managers, and including some of the members of parliament to make sure that they are on board. And also when there were green lights that this would be turned into a law, the team also helped in drafting legislative papers and directives as well as guidelines for the implementation of the new law. And finally, these steps, of course, helped the lawmakers to finally approve the recommended tax, not just the recommended tax between 5 to 10%. In fact, the government took advantage of our study, and they in fact raised taxes on these products by about 20% in general. So finally, just to give you key lessons from this case study in terms of evidence to policy. So the involvement of stakeholders or people who are using the evidence in identifying the research problem or evidence need, and if possible also including them in the evidence generation process is critical, because they will have ownership of the evidence and they know why they need it, their gap, and they know that they were involved in generating it. So the probability of using the evidence to policy will increase if one involves them in identifying the evidence need. And a strong dissemination would be critical as well. And it's important to involve all key stakeholders, and also to create a platform where they can discuss, not just present the results or the findings and the methods extra, but also to give them the chance to reflect on the results, and also give them the chance to include their recommendations and thoughts into the final product. It's really important. And it's also important to prepare a less technical and brief, a short kind of policy briefs, which will be read and understood by relatively busier people, policymakers, program managers, and so on. That will also increase the chance of them reading and understanding and discussing among themselves. And as I said earlier, the involvement of key stakeholders, including, if relevant, members of the parliament, and then also to create an advocacy platform with this, stakeholders would be critical. And finally, of course, favorable policy environment, some champions in the policymakers, and then also the timeliness of the issue at hand is critical to increase the chance of success for evidence to policy. I'll stop there. Thank you, Peter.
Very good. Thank you. Thank you very much, Girmay. I would ask the team to advance to our next slide. And this introduces our last speaker, Dr. Tista Tilahun. Tista has been leading our work with the Oromia Regional Health Bureau. Oromia is the largest, most populous region in Ethiopia. And a little bit of background on her on this slide. And Tista, I'll turn the floor over to you.
Thank you so much, Peter, and thank you for your participants. As already said, I'm Tista, and I present about the subnational activities of Fenot project in Ethiopia. So these are the outline that I will present after. So when we see the Oromia regional state as one largest region in Ethiopia, as you see from the map, it has 21 zones and 19 administrative towns. There are also more than 300 districts and rural towns. The regional population is projected to be about more than 14 million. And in the region, there are 92 hospitals, about 1,400 health centers, and also more than 7,000 health posts. When we come to this experience from the national, the subnational, that is from the Oromia Regional Health Bureau, what abbreviated as RHB. And then is EPIC. EPIC is Evidence Performance Improvement Collaborative. This is a team formed by Fenot to create research environment among the staffs of the Regional Health Bureau. So what this team was doing was identifying priority areas and try to research and do evidence generation works using the routine data and to be for the use of decision making at the Regional Health Bureau. So we try to see that in the way and try to do an evaluation like use the data from the integrated supportive supervision. I think you know that mostly in most countries there are integrated supportive supervision in the health system of the countries. Similarly, there is in the Ethiopian context also, particularly to the Oromia Regional Health Bureau. So we went to use data from the integrated supportive supervision done once last year. And then what we found is rather than using the data that from the integrated supportive supervision, the data quality was poor. So we diverted our interest toward this rather than using the data. It's better to evaluate the data quality where the data collected from the integrated supportive supervision regularly. So that is the idea why we want to evaluate the integrated supportive supervision done by the region. So the objective, as I said already, is to evaluate the process and also to identify the strengths and gaps while they implement integrated supportive supervision. And finally, we try also to see the interconnection between the integrated supportive supervision done at the ministerial level and also the regional level, and their interconnection in terms of the feedback and other process of the implementation. The methods we use as the first one is qualitative data. As I said, the data quantitatively and qualitatively collected from the routine integrated supportive supervision. So we tried to use qualitative data, but actually we want to support it by using qualitative data that actually the team has generated and collected from the different stakeholders involved in the integrated supportive supervision. So we conducted a key informant interview among 4 supervisors who participated in that integrated supportive supervision, 6 supervisors from the facilities in the region where the integrated supportive supervision has already done, and 2 coordinators who coordinated initially the integrated supportive supervision activities at the regional level, and also 1 focal person from the Ministry of Health. That is a key informant interview. In addition to that, we have done also a document review of the integrated supportive supervision checklist and also cost-related documents. As you know, there is cost while supervisions have done. And the quantitative data, typically we get from the checklist data because when they go to the field to do the supervision, usually they use a checklist. So we use that checklist as a source of quantitative data. The facility levels are health posts, as you know, the last or small structure in the health system of Ethiopia, there is post, and also then is health center and hospital. So we use data and checklist data for quantitative from the 3 different facility levels: health post, health center, and hospitals. So coming to the qualitative data results, mostly the informants reported major important feedbacks for the the supervision. The first one they said is the budget is inadequate. It's known, but really it's inadequate. So they said it's inadequate. And also data collection tools, because usually they use checklist. We're lengthy and not focused. And also at the different levels, while they performed the integrated support and supervision, they said they lack commitment. Lack of transportation is known as it's a poor resource setting, but actually there is a lack, even there is an access for transportation. And also what they have said, the experience is supervisions done by different organizations, whether it's government or non-government. But when we see the supervision and the use for the facilities, there's a little support. So as I said, maybe it's important to focus on these issues also. Regarding to the quantity results, as the table has shows, you can see that when they start doing the supportive supervision, actually they sampled the health facilities to perform the supervision. And then they sampled with health posts under 20, health center 80, and hospitals 89. Unfortunately, we managed to get only checklists for these facilities with a low percent. As you see, for health posts, it's only 20%, health center 50, and hospitals 25. This checklist is a completed checklist returned to the regional health bureau. So it's difficult to actually say that this finding represented the whole region, but actually we can say that this is also a finding that can help the regional health bureau to improve the integrated supportive supervision in a different way. So the challenge is, as I said, it's incomplete and inconsistent checklist used, and also not adequate to conduct extended performance analysis, generalization or representation of the region. And also opportunity, it has an opportunity actually. This is because it has different sections of different programs and different program data. It could be helpful if it's fully complete and then analyzed for the different health programs and the entire health system in the region. Just to show that the health extension package, I think you know health extension is an important one and usually mentioned as a role model at Ethiopia in implementing health extensions. So it has a package, as we have with this health extension package related data from 72 health posts. So you can see that how the different programs of different services are delivered at the health post level. You can see that is about around 79 in terms of long-term family planning, but you can see that it's lower than 50%, like updating of family folder, because it's expected for the health posters to have a record of family members in their catchment area. And also you can see that whether making home delivery free are only 45, it means still above 50 years home delivery. And then you can see also that home delivery is related with also skilled attendance or delivery by skilled attendance is only 52.9. So you can see that these all the things indicators how the performance of these health posters is far from the expected achievement targeted for the health extension package. When we see the challenges in the implementation of supportive supervision at the RMNCAH region, as you know, there are different stages for this integrated supportive supervision. The first one is pre-visit. And when we see pre-visit, there is poor attendance in terms of like orientation and others. And also questions in the checklist are not clear. We can say that while we want to enter to the data, say like STATA and the others, we had a challenge because the questions were like 2, 3 in one and also extended, not suitable to do analysis and others. The other is a lack of time and commitment. So they rush to go to the supervision, but actually commitment and also preparation for the data collection and other procedures is very short. And lack of adequate resource, as I said, related with budget and also management activities. During visit, the challenge mentioned were like short time of visit, so not enough time to supervise actually, and also support at the facility level. That includes also challenge in terms of lack of consistent or uniform reporting form, lack of orientation for the supervisors or who participate in that integrated supported supervision, and lack of focus in use of checklists. So checklists be used and also to be full completely and returned, but not actually doing that one. So it shows that the lack of focus in use of checklists, and follow up on previous feedback, because there are a lot of frequently done supervisions, but actually there is no follow up. That's also one thing that is a challenge during the visit. The last one after visit is a post visit. During the post visit, most of them explain that lack of emphasis at all levels, because the level is it starts from the regional health bureau, going to the zone and also Warada, and down to each facilities, whether it's health center, hospital, or health posters. So lack of emphasis in using of the data and also doing the support supervision is one, and also understanding of the value of data use is one, because if they understand, they can do completely fully, and also store in a manner that could be used for the future too. So that's related with data storing and also data management activities. It's not only for the small level of the health system, but it's at all levels of the health system, starting from the regional health bureau till down to the each facilities. So what we see is in a different way before, but now we can also see that at the ministerial level and the link between the regional health bureau. That's national and sub-national levels. So you can see they have their own objectives and making of or doing or performing of this integrated supportive supervision, like at the ministerial level is they make actually integrated approach way, and also for program implementation to identify the challenge of each regions in the country, and also provide support and decide best experience. While regions at the sub-national, they want to validate their routine report at the different levels, Warada, zonal, and also administrative levels, and also to identify their own performance gaps and also to provide support. The timing for this integrated supportive supervision at the ministerial level, they do once per year, but it's expected to be done quarterly at the regional level. And the process is similar, but it's a bit detailed in the regional health bureaus rather than the ministry level. Information sharing is an important one, and mostly what lacks here is the presentation is done federal level and also regional forum, submit written feedback findings. When we ask for this, the regional health bureau, how they are communicating with the ministry level, they said there no clear way of communicating and identify gaps from regions to Ministry of Health. So that's an important one, how the ministerial level at the national and sub-national level are related with in terms of implementing or using integrated supportive supervision. We think that these are important to do integrated supportive supervisions. But there are also other important things to be identified or to be also clear with at the regional health bureau. So what we said is the regional health bureau should make informed decision based on the result of ICES. That's an important thing. But still they don't know about how many integrated supportive supervision in a year, maybe for the different programs or at the regional level they are performed. And also the data handling and longitudinal data establishment at the regional level for proper follow-up, because the challenge is data storage, data management, and using of longitudinal, because there is no any data stored to assess and link the previous or consecutive subsequent integrated supportive supervisions at the different programs in the region at the different time also. And the other thing is the importance of knowing really what we cost we are using it. So its cost effectiveness analysis should be done while we perform also integrated supportive supervision. So what is the next step for the Regional Health Bureau? I think still we are working on it, and we will have also workshops because now the region had said, okay, we need also guidelines. So we are going to develop a guideline for the region, and we planned a workshop at the end of this week, and there will have a team formed for that group to develop the guideline and submit to the Regional Health Bureau to use for the future activities related with integrated supportive supervision. Thank you.
Great, thank you, Tista. So that completes the formal presentations of this session. And we're now going to be able to move to Q&A and discussion. I believe all of our presenters are present together in Addis Ababa. So it should be possible for them to choose respondents to some of these questions or have more than one respondent. And again, let me remind participants that questions can be entered on the conference platform webpage for this session. They do appear on my screen, and they are weighted by the number of thumbs up that they're given. So I will try to give some emphasis to the more popular questions first, but we'll try to get everyone's questions in. I did note there are two questions that got the most weight so far, but one came in earlier than another. So I'll start with the earlier one. And this is from Ralalasia Limato. And she writes, in many contexts, policy decisions are made with considerations of the interests of many parties or political parties. How does evidence-based research, how can evidence-based research compete with these various interests to have a positive influence on outcomes? So Merkusi, maybe you can coordinate the team in Addis to try to answer that question.
Yeah. So Samuel will respond to this question.
Great.
Okay, thank you for the questions that are forwarded after the presentations. That means there was a lot of attention to the presentations. So we've tried to also share the questions among ourselves. So we'll be responding on issues which we think will be relevant for our area. The question with regard to the keeping the balance of interest between different parties when using evidence or decision making is very interesting. As I have already tried to indicate, the policy making process is a very complex process with multiple agents involved with different interests, power relationships, expectations, and influencing power. So I think managing these interests need a very careful attention and skill. And there are multiple ways to do that, but in my view, the most important part is working together, creating a trustful relationship and creating that platform for engaging key stakeholders. So everyone has a room to speak their mind and come forward with their expectations. At the same time, also be able to understand the expectation from the other side of the table. So I think this process of engagement, multi-sector engagement, or what we call the co-creation process, is very important in keeping balance of the different interests. I think it is easier said than done. In reality, it takes a lot of effort to do that. we've seen that within our project. For example, when a new initiative comes, there are proponents for that initiative, there are opponents for initiatives, and there are who are very interested, vested in that intervention to fund and expand. Others might have a different project that they want to implement. So I think this is a reality. In fact, through our project, what we've been trying to do, one of the key things that we have identified through our engagement is giving the capacity for policymakers or those who are at the position of making decisions to have the skill for managing expectation, managing key stakeholders like communication skill, leadership skill, and also engaging different interests in an appropriate manner. So I think these are some of the things that I can say. But as I said, there is no straightforward answer to this question. So I have to stop here for the sake of time, Peter.
Okay, thank you, Sinuel. So our next question from Barbara McPake. Hi, Barbara. Is both a comment and a question. I'll read it. Barbara writes, I think the relationship between evidence and policy ought to be conceptualized a little differently from how we are often expected to do it by funders. Of course, the research we do is for policy purposes, and there's no place for health systems research in Ethiopia that isn't constructed with that in mind. But it might not be the case that one research project, especially a relatively small one, should change policy. I think good policymakers should look for an accumulation of evidence that points in a particular direction rather than jump back and forward as different research projects say different things. Evidence is complex, like everything else about health systems. How can we educate funders to take a systems approach to the role of evidence in policy?
So Peter, I will go for that. So as clearly mentioned in the question itself, it's clear that it is a very complex process and evidence use itself is just a piece in the policy making process. We understand that. And what we encourage to the staff of the ministry and the regional health bureau is to not only to focus on a single presentation or a single paper in making decision. Rather, as I've described in my presentation, for example, the Research Advisory Council at the MSH Directorate does synthesis of best available evidence from local, regional, and global evidence to answer policy relevant questions forwarded by the staff at the ministry. So we don't promote use of a single research like for making decision, and that's not possible, clearly. Rather, we encourage the culture of using evidence, best available evidence to inform decision making. In terms of making funders to take a systems approach, so in our health system, there are different players, one of which are funders. And in our evidence policy workshop, we also invite partner organizations, professional associations, which are involved in some way or another in funding and running research projects. And for them to understand, we highlight that for them, there is a need to understand how complex the evidence to the policymaking process is and how the role of evidence could be affected or shaped in the course of conflict or interaction between actors and interests and ideas in the policymaking process. So yes, it's very complex, and we don't promote use of just a single research, but we are trying to change or shape the culture through different platforms and workshops to all actors, including funders. And Samuel would like to add.
I think one of the key things that has been raised by our colleague Barbara is the system thinking approach. as we have tried to highlight in our presentations, the big missing piece in the Ethiopian landscape is the coordinating mechanism, or a system, a governing system, which can operate at different levels, from the policymakers to the lower implementers level, in terms of having a smooth function. So I think in the absence of that, it will be very difficult to bring in a very integrated, well-coordinated system for this type of function. So I think that is the key. And we have highlighted that Ethiopia needs, I think not only Ethiopia, any country needs that type of system, which has, it has to be agreed upon what type of system we have. I think there are different ways, mechanisms, but I think we need a system that governs and controls, or have oversight about this function. Thank you.
Okay, thank you, Sinuel. I want to add one thought as well to what Mercusi mentioned about the research advisory councils. One of the things that we think has been valuable about this is that they convene groups of Ethiopian experts to review the evidence that is provided, often through projects that are run by different international partners. And this, I think, provides a more local voice to the discourse, which I think has proved valuable to the government, to be able to have a vehicle for hearing that local voice in a more organized way. Okay, the next question from Ibrahim Yisa. Does the government of Ethiopia support research efforts with funds? If not, how are you resourced for research?
Yeah, it does, but it provides funds to government or public institutions, including universities and the Ethiopian Public Health Institute, which is the research wing of the Ministry of Health. And it also provides support to other research evidence generating institutions of the government system. But in our case, our time and our support to the different platforms we support in the evidence to policy function comes from the Bill and Melinda Gates Foundation. So our fund doesn't come from the government.
Okay, thank you. Next question from Felix Obi. In capacity building, how do you measure the outcomes or overall impact of the different capacity building approaches over time? What specific metrics have you used to evaluate the results of the initiatives? Are there papers or publications out there that you've done that we can reference? From Felix Obi, HSG board member.
Yeah, this is a very important question. We have started initiatives to document and evaluate the outcomes of the capacity building activities. But, in the workshops, in the formal workshops, as usual, we do pre-post assessment of participants. Apart from that, we follow up. We have a close working relationship with the staff of the ministry and, of course, the regional health bureau. So we follow up on and support them. And we see also the changes in the way of doing things, the way of making decision, their appetite for looking for additional evidence in making decision. So we are witnessing change, but we have not, prepared a document or a publication to share with you. We hope to do this in the future. Yeah.
Just to add on that, we don't have a specific metrics, monitoring metrics, as our colleague asked, but we have an indirect way of assessing how our interventions are impacting the system. So one of the things that you have asked is if we have publications, and I think you have seen some of the publications during the presentations, and we are very happy to share the outputs as articles that have been published in peer-reviewed journals. But apart from that, we have lots of success stories, and one of our plan in the future is to properly document these case stories or best practices and share it for local as well as for the global community to learn from that. And we can mention some of, for example, I can personally mention things that have been in place. For example, the Maternal Child Health Directorate was planning to introduce a birth dose of hepatitis B vaccine. We are already giving hepatitis birth dose, hepatitis vaccine for children as part of the pentavalent. So they are not receiving it at birth, they start from 6 weeks. So the plan was to introduce that. But one of the questions is, was it cost effective? So automatically, since they have already now, they are sensitized on using evidence, they forwarded this question to the Research Advisory Council and asked the team to really bring the evidence if this intervention is going to be cost effective. So the team took up that question, did meta-analysis, systematic review, and provided the synthesized evidence. And then based on that, they made a decision. So these are, we have several type of these stories to tell, but one thing which remains is to really document and make it available for others as a learning process. Thank you.
Great, thank you, Sinuel. Okay, the next question from Judith McCool. What are the key success ingredients for shifting the views of policymakers in this context?
Yeah, so, in our engagement, for example, just to mention with national level, the Ministry of Health, we have seen that, now it's customary for the staff of the ministry to look for an evidence before making decision about, changing a guideline or creating new guidelines. And for this, there are several examples. For example, one of the Research Advisory Council thematic group, which is a maternal and child health thematic group, was given a task of working on a question about how to improve the situation in relation to postpartum hemorrhage management in the Ethiopian health system. So they did a review of the existing evidence, looked into recommendation by WHO and other global agencies, then came up with suggestion of including more interventions to take care of this leading cause of maternal mortality in the country. So PPH management by use of UBT and tranexamic acid and NASC were suggested after review of the existing evidence. Now the ministry has included NASC and UBT already as part of the PPH management in the Ethiopian health system. And this was done after they got the technical brief or the policy brief from the Research Advisory Council. Even in our day-to-day encounter with the MCH Directorate staff, we have seen that whenever they are encountered with new initiatives, they look for evidences, such as inclusion of new vaccines or changing preparations and dosage, things like that. So we have several success stories which we will document and share with others in the future.
Okay, thank you, Merkuzi. I don't know if any of the other team members would like to comment on their view of success factors.
Thank you, Peter. I would like to say something on that one. So being a member of the maternal health team as part of the Research Advisory Council, we have very good experience with MCH Directorate. And to mention here, there are a number of different teams. They call it case teams. So one of the case teams is maternal health case team. So I'm also working as a team carrying out these different types of analysis. So just to mention one, we also, as part of the team, what we did was an additional intervention for the PPH management in Ethiopia after doing systematic and meta-analysis, systematic review and meta-analysis. We came up with one suggestion, that is to distribute misoprostol as as a convenient tool or intervention to reduce maternal days from postpartum hemorrhage. So I think the team came up with this suggestion. So what happened later was the MCH directorate arranged a policy dialogue session. Then our team presented on that one, and there were a number of people like experts, decision makers, and again implementers. So later, it is decided to try in a small scale as implementation study. So the Ministry of Health is looking for some funding to assist the implementation study in the Ethiopian context so that it can be used at community level as a feasible strategy to reduce PPH as well as reduce maternal mortality. Thank you.
Great.
Peter, a bit of an idea about the success factors. I would say the success factors in the MCH directorate and the regional bureau also comes from the idea of co-creation. We don't create the questions. The questions are usually forwarded by the staff of the ministry. Then we craft and do the prioritization. We support the team in locating the evidence. Then we provide the answers to the questions posed by the team itself. So the policymakers pose the questions, not the researchers. That's why it is successful. And also it's done, as you said, by local people. It's contextualized. It's not only a recommendation of like a global or a regional agency. It's rather a recommendation by local people to the local system. So that's why it's successful, I would say.
Great. Thank you, Merkuzi. Okay, the next question, if I can move on, from Kenneth Yakubu. Since membership of the Ethiopia Quality Commission is voluntary, how is sustainability of this initiative achieved?
Okay, I think this question is for me. So, as I said, when we initiated this commission, there are a number of experts working or supporting the Ministry of Health by engaging in different technical working groups or as independent researchers or university staff. So what we did was based on actually the selection of these volunteers was made by the MCH directorate, specifically the director of the directorate. So the selection was based on their willingness, the experts' willingness to contribute to the country as well as to MCH directorate. So they were, based on their expertise, they were invited to take part in specific questions which were identified by the MCH case teams, as I mentioned earlier, because one of the case teams is maternal health case team, there is a child health case team, and so on. So these people, the experts were volunteers. They were not expecting any kind of incentives or payment. So what was done to motivate these people was the ministry, at the end of the completion of the tasks, what was done was the ministry wrote a recognition letter to each of the participants. So initially the commission was founded for 2 years because that was initiated by the Lancet Global Health as part of the high quality health systems. But now these members, all of these, I can say all of the team members are engaged in different technical working groups, which we are also part of it. And they are also members of the research advisory councils, and they are still continuing support to the ministry with regard to the priority topics identified by the ministry. So what I can say here is, yes, I agree, volunteerism is a very complex thing, and it's very difficult to maintain people to continue providing support or doing analysis. So what we are doing is, these people are part of the technical working groups and the research advisory council, and whenever research questions come from the ministry, we invite them to engage in different technical working groups, not as part of the quality commission members, but not part of specific technical working groups. So they are still engaged in such activities to assist or to provide technical support to the ministry. I think Murkuze can add something on this one. Okay.
Yeah, Peter, moreover, this sustainability issue is also taken care of by the fact that the staff, the motivation from the members for the RAC and the Quality Commission, it really is not, like payment. It's rather their participation is taken as like a prestigious, it's an honorable invite from the health system to researchers. There is a lack of linking researchers and the health system in this country. They don't usually work together. And when the opportunity comes, the researchers usually take it up. And what we do to motivate them is they ask us to write a letter of appreciation. They use it in the universities for promotion and others. And so this is sustaining. Currently, we have a pool of researchers who are willing to be called into the thematic groups of the Research Advisory Council whenever we want them. So they willingly register. So anyone, if anyone leaves a team and if we are looking for any skills, additional skills, then we can invite from our pool. Moreover, we also intend to transition this activity to the, supporting the Research Advisory Council to the regular government system. It's, and for that, now the directorate, for example, the MCH directorate has included indicators for following up, success in the directorate, like in the annual plan of the directorate, indicators like the questions forwarded, whether the questions were taken care of by the RAC and responded, and what was done by the respective case team in the directorate. So the health system itself is following up what's happening. So we believe it will be sustainable because of these factors.
Okay, thank you. Next question from Kaukab Mohammed Al-Haddad. The conference being held every 2 years, is there any possibility that the next conference could be provided online to allow participants from other countries to join?
I hope so. Given the current context, we have to have an option of making it online. Otherwise, we cannot gather, the number of people. It's planned for August 2021. So we don't know what would happen then. If possible, we will make it face to face. Otherwise, online would be the option. And at the same time, another question related to this, it was mentioned that is it possible for other African who are interested to join the conference? Yes, it's an open conference. It's possible. The only thing one needs to do is registration before seats are full. So it's possible, it's open, but so one can cover his or her own expenses and can join the conference as long as he or she is registered in time.
Okay. Thanks, Mercusi. We've certainly learned from HSG the potential for having very wide participation in online conferences. So maybe this is, I would say that's also technically challenging. So I would say that let's look into how that could maybe be, those lessons could be incorporated by next year in the next conference. Next question from Chloe Brooks. How have you assessed what tangible effect, if any, these activities have had on strengthening the use of evidence for health policies?
Yeah, I think we already said this. We have not systematically documented this, but we have several cases showing that there is a shift in the attitude of the staff. They are having better appetite of using evidence in making decisions. There are different cases. We have already mentioned examples. I think what is remaining is we have to document those and share it.
Okay, thank you. And the next question from Gina Teddy is kind of the same thing. So perhaps we don't need to give it another answer, but I want to read it just to give voice to it. Some of these activities, such as policy dialogue and research conferences, have become talk shops and indicators for deliverables for the funding requirements. How do we actually ensure that these rich findings and evidence actually inform practice and policies, but most importantly, get the political buy-in they require?
Yeah, yeah. As earlier said, we have ensured that questions are not created by researchers. Rather, they are initiated from the policymakers themselves. And as we said, from time to time, the appetite for evidence use has improved. And, this time what we have witnessed is the Minister of Health, for example, does not directly use what's recommended by WHO as it was previously. Rather, it forwards questions to whether it is feasible to do it in Ethiopia. For example, the birth dose issue, it's approved by WHO long ago, but it was not done in Ethiopia. So they wanted to be sure that it will be cost effective and sustainable for the Ethiopian health system. There are several. For example, currently the maternal and child health, the maternal health thematic group of the Research Advisory Council is considering the feasibility of adopting the new antenatal care, the positive pregnancy guideline, which was published in 2016 by WHO. So increasing number of visits like to 8 from 4 and things like that. There are several recommendations in that guideline, and the team now is considering its feasibility and how it is doable in the Ethiopian health system before plans are crafted in the ministry to implement it.
Okay, thank you. Just to also note, Zia Sultana also asked, does policy dialogue have an outcome in shaping up policy? And I think we've heard many examples already of this. So thank you for that question. Arun Kumar Agarwal notes, in India, there is a National Technical Advisory Committee on Immunization, and there are many technical expert groups under it. All evidences are thoroughly examined, and then the National Technical Advisory Group makes recommendations to the government for policy decisions. Recently, many newer vaccines have been included into national programs with this mechanism of evidence to policy. So this is just an experience in sharing comment that there are other examples in other countries. And I would note that it's very valuable to document these other experiences as well. Any developing, growing health system that wants to improve its performance should have some mechanisms in place for this kind of evidence gathering and synthesis, I would say, in a more normative way. Ibrahim Yisa offers this feedback. Most countries in the past have not been sensitive to evidence-based policies and decision-making process. COVID-19 has changed all these. How are we taking advantage of the lessons from COVID-19 to generate evidence that has direct consequences for health, social and economic impacts, and using the evidence for advocacy for political leaders and policymakers?
Yeah, I think almost every one of us in Fenot have participated in several national and national technical working groups. As our colleague already said, the ministry and the regional health bureaus wanted us to come up with, recommendations, suggestions, because this is a new development. There were a lot of engagement from our team and different experts in the country to feed the evidence. And we have witnessed that, as it was said, there was a change of attitude because of COVID, because it was a new thing and they didn't know what to do. So they really asked questions, and we provided assistance in several instances. Our colleagues can add on this.
Yeah, I mean, this is also a very good point. And I think one of the pros and COVID is it has exposed more systems, including the evidence to policy systems. as well as also it has given momentum for certain actions, so because of highlighting the gaps. So what we're trying to, our colleague asked if we are taking this advantage and in terms of pushing the agenda for evidence to policy system improvement. Yes, we are taking that advantage opportunity. Previously, we have been asked by the Minister of Health to sort of start a dialogue in terms of bringing strategic recommendations for setting up an overall general system for evidence use in the health sector. And that discussion have been delayed for several reasons. But now, since already it has been, the gap has been already felt because of COVID, and there is a clear need, I think we will be able to reinitiate that discussion at a higher level and arrange a policy, high-level policy dialogue, and probably push our agenda a bit further. So using this opportunity. So our plan is to engage high-level officials, including the Minister of Health and our colleagues, and deliberate on strategic ways of addressing this systemic issue. So I'm just highlighting on using these opportunities, the COVID opportunity.
Okay, thanks, Tsinua. We have about little less than 10 minutes left, so we're going to try to rapidly go through some of the remaining questions as best we can. I want to add on the COVID-19 question that one thing we have learned around the world, that even countries with very large, high capacity evidence generation systems, I won't name them, sometimes have difficulty using evidence in a clear and consistent way. So this is not only about capacity, it's about systems and structures and processes. Uche Ebenezer, R4D Nigeria. The disconnection may be narrowed if there are deliberate efforts from researchers to involve policymakers using a systems approach that is familiar to both sides. Is this evidently happening at both the national and subnational levels in Ethiopia?
Yes, I think to some extent it's happening, but it's not happening spontaneously. It's happening because of the efforts that are put from different directions, including our efforts.
Okay, thanks. Elizabeth Shayo. And I think Elizabeth also asked earlier if the PowerPoint would be available. And I understand it will be available on the conference website once all the materials get uploaded. She asks, can you share the experiences and challenges of involving program managers in identifying problems and synthesizing the information available for usage? She's trying to reflect in her country on a sustainable approach, but how to do it, getting program managers involved in identifying problems.
I mean, Marcuse will respond to that. After that, probably Peter, with the remaining minutes, there are some questions about, taxation and so on. So probably, Girma, you have already answered with the chat, on the chat. Okay, Girma has already written the answer.
So in terms of the challenge, these people at the ministry, be it at the ministry or regional health bureau, they are very busy with their routines. By routines, I mean, they do plans, write letters, talk to partners, do supportive supervisions. The routine is really making them very tight in terms of time. So usually they will not have the time to really do the search of evidence themselves, do synthesis, but they can support the kind of platforms that we have set up. For example, the RAC or the scientific advisory panel at national level. So yes, it's very difficult, to get their attention. It's not easy, but with continuous engagement with them, with change of attitude about use of evidence, it really has got much better. So the challenge is they don't have really time, and it's not easy to get their attention. But with time, and it's getting better, I would say.
Okay. Thanks. Ismail Munira comments that we need knowledge brokers and agencies who can help the policymakers gather available evidence and synthesize the evidence to develop and change policy. And I think we agree with that. This has been a challenge to create for the government, the ministry, to create a consistent knowledge broker or agency to play this role. Something we've been working on for years, but it still remains a work to be accomplished, we think. Patsy Operaku asks a question. I'm not sure I fully understand it. I'll read it. What is the place of COS, which may mean companies or cost, I'm not sure, in all this process, given the relevance in the communities where these researchers are implemented? How do you build their capacity? Perhaps it is community organizations is what she means. What is the place?
Yeah, so far we have not engaged community organizations. We work with professional associations, partner organizations like funders and NGOs, international and local. And we also work with universities, public and private research institutions. So these are the players we have been working with. We have not worked with community-based organizations.
Okay, thank you. Zakaria Belriti asks, hi, I'm Zakaria from Morocco, National School of Public Health. I was wondering whether there was any scoping review effort to accumulate evidence from other similar initiatives in evidence-informed policymaking in Ethiopia, projects like EPHI, SURE Initiative, and how the Oromia Regional Health Bureau EPIC team has accumulated and added insights to what has been done before. What kind of learning organizational processes are in place?
Yeah, so time is running out. Tizita will be addressing this.
Okay, thank you.
Yes.
I think regarding to the Oromia Regional Health Bureau, particularly EPIC team, as I mentioned some of the things now, EPIC team, we have changed it into scientific advisory panel because of some challenges related to commitment and also involving of the higher officials and also the directorates who can make a decision in any activities in the Regional Health Bureau. Now is a scientific advisory panel, which is consisted of universities, staff, and directorate, and also directorates in the different directorates in the Regional Health Bureau, and also program managers. Related to the other organizations like EPHI and also AHRI, I can give an example how we are also working with them, because these days we are working on the protocol development on serology test to link with the reopening of schools. And now people from AHRI involved in that, and also universities from Jimma University, and the Oromia staff and the surveillance team at the whole, because we are supporting the surveillance and also directorate at the Regional Health Bureau after the COVID pandemic happened in the country. So I think we are involving also different parties, whether it's government and non-governmentals, even partners working in the Regional Health Bureau, who have a relevant involvement and participation in the team that we formed for different thematic areas in the scientific advisory panel. And I think officials understand also that, because there are a lot of questions now coming, like documenting the interaction response of the surveillance and other things coming from EPHI over the region.
Peter, I think you don't have time to wind up. It's just 1 minute. So
yes, okay. So, well, we do have a few questions still unanswered. I'm afraid we're not going to have time to take all the questions in the remaining 55 seconds. So I want to just take the last few seconds to thank the team in Ethiopia. Tista, Girmay, Baraket, Mirkuzi, Tsinuel, thanking all of you for very stimulating presentations. There are many important challenges faced by our group and as well as similar efforts in other countries. And we hope that the participants in this session have found it stimulating and interesting and will help them in improving their practice. So on that note, I think that I should 3, 2, 1 say thank you very much to everyone. It's 2 in the morning here. Have a great day. Last slide, Merkusi.
Thank you. Thank you.
And please note, you can go back to the timeline, upper left-hand corner of your screen for the conference platform. And please do see the posters and other sessions.
Okay. Thank you. Thank you.
Peter.
Good night. Good night.
Good night.
Okay. Thank you, everyone.
Bye.
Okay.